everyone. Hope you're all well. My name is Darwin Chimba. I'm a medical student from Copperbeck University School of Medicine, and I'm also the president for the Association of Future African Neurosurgeons. So we are happy today to have this wonderful presentation that is going to be given to us by Dr. Jean. It's going to be introduced later on. So it's really a great pleasure to have him and to have this presentation today. So before we begin the presentation, we're going to go ahead and introduce ourselves. Everyone on the panel, they're going to introduce themselves. And I'm going to be calling out the names as they're appearing on my screen so that we get to know each other before the presentation can begin. So firstly, I'm going to call on Dr. Aminata. You can please introduce yourself. Then Dr. Kennedy Kimani, please introduce yourself.
Hey everyone, my name is Kimani from Kenya. Pleasure to be here.
Thank you so much. We're happy to have you. Please, when you introduce yourself, you can please add the title and your professional level so that we are able to interact well. Then Dr. Mustafa, please, you can introduce yourself.
Okay, this is Musakanya Shturuka, medical student from Copperbelt University, Zambia.
Thank you, Musakanya. It's a pleasure to have you. Then Neontle, please, you can introduce yourself.
Hello, everyone. This is Neontle Sakaiwa from Botswana. I am a fourth-year medical student at the University of Botswana School of Medicine.
Thank you, Neontle. Thanks. Dr. Anthony. Okay, as we work on him, Olalua Ezekiel.
Greetings, everyone. I am Olalua Ezekiel Dada. I'm a second-year medical student from the University of Ibadan. I'm also the research director of the Association of Future African Neurosurgeons. I'm glad to be here. Thank you.
Thank you so much. Right, then Dr. Oric.
Yeah, thanks, Darwin, and thank you, everyone. Thank you, Dr. Nancy, for putting this together, and Dr. Jane for making the time. Before I present myself, Darwin, I just think that everyone else can present themselves by typing in the message section as a comment.
Oh yeah,
we can read that so that we can get Dr. Jane started as soon as possible. So I'm Ulrich Sidney. I'm the founder of the Association of Future African Neurosurgeons, currently a postdoctoral research fellow in cerebrovascular neurosurgery at Geisinger, Pennsylvania. It's a pleasure to be here today. So everyone else should just send their presentations, introducing themselves in the comment section.
Right. Thank you so much, Dr. Oric, for that. So yeah, please, everyone can just send your introductions in the comment section. At this time, I'm going to hand over to Dr. Nancy. You can introduce yourself and also introduce the presenter, and then you can go ahead with the presentation. So we are so happy to have you, Dr. Nancy and Dr. Jean. Please, over to you, Dr. Nancy.
Thanks, Darwin. It's a pleasure for me to introduce Dr. Jen today. He is one of my senior residents, and I've known him for quite some time, thankfully, and he's a wonderful teacher. Dr. Jen went to undergrad in med school at Hopkins and is finishing his residency in neurosurgery at Hopkins, interested in our complex spine and the use of robotics for pedicle screw placement. He is finishing up next year and will be the head of complex spine in the Northwell system in New York. And I am incredibly glad that he made the time to join us and give this presentation. And I'm very grateful for him to be able to teach us today. So I will hand it over to Dr. Jin, and he can start sharing his screen and impart some wisdom onto us.
All right, I don't know if I can impart any wisdom per se, but I can certainly give this talk. Thank you, Nancy, and thank you guys all. Very happy to be here giving this talk for Association of Future African Neurosurgeons. So thank you very much for the invitation. Can everyone hear me and can everyone see my slides?
Yes and yes.
Yes and yes, perfect. All right, great. All right, so again, I'm Yike Jin. I'm one of the PGY 7 7th year neurosurgery residence, and this is my last year, and I am very interested in really all things neurosurgery, but most specifically complex spine. Today I'll be talking about sort of the basics. I mean, this is kind of a very big topic. I want to sort of touch on a couple of the key points on spine biomechanics and instrumentation. And I have no disclosures. And yeah, if there's any questions, feel free to throw them in the chat, and I can answer them as we go, or either way. Whatever works here. So let's see here. So an outline of my talk, I'll start off by talking a little bit about just general anatomy of the spine. This obviously will be a review for many of you, just so we sort of make sure that we're all talking about the same sort of terms and terminologies, and then really delve into the idea of what makes a spine stable. What does spine stability really mean? And how do you determine whether something is unstable and requires surgical intervention? Then I'll talk a little bit about spinal balance and alignment. So the idea that not only is it stable, but is the alignment such that the biomechanics and the forces that are exerted on the body are balanced and ideal. And then ultimately we'll talk about instrumentation and how to answer the question of, is it harmonious, and how to sort of choose an instrumentation to better ensure not only fixation, but sort of long-term stability in order for bony fusion to occur, which is the ultimate goal of spine surgery, or at least fusion surgery. So starting off really quickly, so the spine obviously is broken up into multiple different segments. There's 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and 5 fused vertebrae that make up the sacrum, which really ends up acting as a single bone. And then your coccyx or your tailbone usually is either 3 to 5 segments. So, one thing that I won't talk as much about, just because I think it truly does warrant a separate talk in itself, is really the occiput to cervical junction, and then the C1-2. It's there's a lot of things going on here, as you can tell by the diagram, a lot of different ligaments, a lot of different classifications of stability and things like that. And I think I'll just for now leave that for a separate talk. But suffice to say, if you look at sort of the morphology of the different vertebrae, you think about it, they all have slightly different morphologies that sort of have things that you have to consider. So cervical vertebrae, you can see a little bit more triangular in shape, and actually notably has the foramen transversarium, which carries the vertebral arteries. Thoracic vertebrae, a little bit more high arching, and notably the transverse processes usually articulate with ribs. And then the lumbar vertebrae, you can see much more bulky, much more weight bearing. So just going through the basics in terms of the parts of the anatomy of a vertebral body. This is a lumbar vertebra, which I think is, oftentimes one of the frequent areas. The lumbar region is a frequent area of surgery, so I figured it'd be good to start with this. I think about the vertebral bodies and the vertebra having 3 articular surfaces, or 3 joint surfaces. You have bilateral facet joints, so your left and right facet joints that connect each of the posterior elements of each vertebral body with each other. So you have the superior articulating process, which is highlighted there in green. You have the inferior articulating process, and you can imagine sort of if these vertebral bodies these vertebrae were stacked on top of each other, that the red, the IAP, would articulate into the SAP, and that forms that joint. And then really, the disc and the vertebral bodies form a joint in themselves also, and we don't really think of them as joints, but really they do function as a joint. And basically that's the interface between the vertebral body and then intravertebral discs, which I don't have showed here, but basically you can imagine our cranial and caudal to the vertebral bodies there. Other notable areas to look at: pars interarticularis, that's this area of the bone there that connects the SAP with the IAP. The lamina, which really forms the posterior ring around the spinal canal. The pedicles, which really connect the posterior elements, the posterior parts of the bone to the anterior vertebral body. Transverse process, which really in the lumbar spine is vestigial, but as I mentioned before, in the thoracic spine act as articulating points to the ribs. And then spinous process, and this is sort of the most prominent you can feel in your own back when you sort of run your finger along your back, though that's the bony prominence in the back. and the spinal canal. Of course, surprisingly, I think I won't be talking as much about the spinal elements in terms of the nervous elements in this talk, but obviously very, very important. Ligamentous anatomy is actually very important for stability as well. And it's composed of, this anterior ligament in the front that's in orange, that is in front or ventral to the vertebral body, is the anterior longitudinal ligament. The posterior longitudinal ligament, which is again behind the vertebral bodies and, in front of the fecal sac or the dura. The ligamentum flavum, which they're actually discrete, non-continuous ligaments that attach to each subsequent lamina. So it's, even though we call it a single ligamentum flavum, there's actually multiple sort of discrete, non-continuous parts that form the ligamentum flavum. And then the interspinous ligament, which is, as the name suggests, between the spinous processes, and the supraspinous ligament, which is, on top of the spinous processes. So overall, spinal stability and flexibility really is sort of, two sides of the same coin, right? So the idea is that, you have so many different movements and motions that you can do with your spine and your torso, that you have to, in order for a person to function well, you have to be able to do these movements such as flexion and extension and, lateral bending and rotation, but at the same time, maintain a certain amount of structure and stability so that you don't hurt the nervous elements that are contained within the spine. And so this is, a very, I'm sure people recognize Spinal Biles, but this is a very sort of well-known So obviously not all of our spines are that flexible, or not all of our spines are attached to, championship winning, Olympic athletes. But, that sort of demonstrates that the fact is, that her spine can, has so much flexibility and so much movement. At the same time, obviously she, it makes sure that all the nervous elements are contained and doesn't cause any injury for her to do something like that. Ooh. Good. So it brings up the question, is the spine stable? Or what does it mean for a spine to be stable? Really, this is a very complex question. And, the questions that sort of the sub-questions, if you will, that you have to think about are, what bony fractures make a spine unstable? So what parts of the spine can be broken and still be stable? And what parts of the spine that are broken, you have to say, oh, now you're unstable and we should do some surgery. What ligamentous tears can make a spine unstable? And how do we sort of begin to classify the different combinations of these sort of, destabilizing insults to the spine, so that we can sort of talk to each other in sort of a categorical or organized fashion? And ultimately, when do we need to go to surgery? So, the first sort of, I think, big, stab at this was by Denis in 1983. He came up with this, this idea of a 3-column concept. Okay, so basically, you took the spine, you broke it up into 3 columns. He says the anterior column is the anterior longitudinal ligament, and then the anterior 2/3 of the vertebral body, and then the associated disc. Middle column is the posterior 1/3 of the vertebral bodies in the disc, and the posterior longitudinal ligament. And the posterior column is everything else. So you got your pedicles, you got ligamentum flavum, the spinous ligaments, and then your facet, pars, lamina, spinous processes, everything basically behind the posterior longitudinal ligament. And so, he suggested that a single column fracture, or at least an injury to a single column, is likely stable, but 2 or more is, probably not stable. And so that was expanded upon back in 2005 when the TLIX classification came out, the thoracolumbar injury classification and severity scale. And so you can see it's very similar to, it has some of the similar ideas to the Denis classification, but it breaks up sort of the predictors of instability into 3 sort of different sections. So morphology, and how the fracture pattern looks, the integrity of the posterior ligamentous complex, so all the ligaments in the back, the interspinous, the ligamentum flavum, is that intact or not? And the neurological status of the patient. And all those are sort of whittled down to a single score that sort of helps you make a decision, 0 to 3 being probably something that doesn't need to go to surgery. Number 4 being surgeon's choice, or, sort of equivocal, and greater than 4 being likely surgical. And, it's interesting to take a look at here, for example, the morphology. So you can think about the idea of a compression fracture, which is a little bit more mild, getting only 1 point, whereas a distraction injury, where the spinous elements are actually, separated apart from each other, as a much more severe injury. And then also looking at the neurological status, it's also important to see that, so if you have a single nerve root injury, or a complete cord injury, then that's a 2. But if you actually have an incomplete cord injury, that's a 3. Now, of course, that seems a little bit, counterintuitive. It's like, well, if you have a complete cord injury, then, why is that not more severe than an incomplete cord injury? And that goes to the idea that, ultimately speaking, for a complete cord injury, and there's a lot of papers that show this, there's less chance of recovery. So, for example, you have a T10 injury and you can't feel anything below your belly button, you can't move your legs, and you have no sphincter tone and no saddle sensation, there's a very low chance that you have recovery. But if you have any of those present, you have some sensation, you can wiggle your toe, then those patients end up having a higher chance of recovery, which makes surgery much more urgent, because the idea is that you could save them and you can either preserve the existing function or give them a chance of improvement. So the AO classification sort of came in 2013. It's a little bit more clunky. I think, in many ways, it's for clinical use, it's a little bit more complex. I do know certain places like University of Maryland will actually use the AO classification, but you can see it's a little bit more thought out. It breaks up your morphologies into 3 different sort of groups based on sort of the mechanism of the injury. So compression injuries, so injuries caused by downward loading force onto the spine. Distraction injuries, again, caused by a motion that basically causes the separation of the spinal elements, and then translation. So these are injuries that have a shear force involved. So basically, where it causes the spine, the two parts of the spine, to shear off or away from each other. And again, it has a neurology section and some modifiers here. So there is actually the AO classification actually didn't originally have any, recommendation for surgery, but rather was more of an idea that you would be able to talk to other surgeons. Okay, this is a B2 injury, B2N2 injury, or whatnot. But they actually then categorized and added on, they asked a bunch of leading surgeons, under what AO classifications would you ultimately go to surgery, and using that modified Delphi approach, we're able to come up with a similar, almost like TLIX type score categorization, where 0 to 3 is non-operative, 4 to 5 is questionable, and greater than 6 is operative. And I know I've been speaking a lot about the thoracolumbar spine, mainly because the cervical spine injury classifications are still a little bit more questionable. They're not as well adapted, mainly because the cervical spine has so much mobility. But there is this subaxial cervical spine injury classification system that's pretty good. And you can see here, it's pretty similar to the TLIX, where instead of the posterior ligamentous complex, they talk about the disco ligamentous complex, basically because, in the cervical spine, the posterior ligaments are actually not as strong. So, question then comes down to, is it stable? So, for example, some examples here, for this, in this case, is a 69-year-old. It's a 69-year-old gentleman that got hit by a side view mirror of an SUV when he was walking, and you can see here, the fractures are here through the spinous process, and here through the transverse, the transverse process. And so, when you think about how to classify this, I guess first of all, you have to know that he has some back pain, but no neurological deficits. So if you think about it from the knee spinal columns perspective, both the transverse process as well as the spinous process are all part of the posterior column, and there's no real injury to the anterior or middle columns. So it's a 1-column injury here. If you look at the TLIX, I would argue that this is, if anything, just it's just a compression. So 1. No evidence of any sort of posterior ligamentous complex instability, and no neurological deficits. So it's a TLIX of 1, which indicates it's non-surgical. And if you look at sort of the classification here based on the AO, it's probably an A0, or just minor non-structural fractures. So stable, non-operative management for this patient. Now, this is a different patient, 82-year-old guy, was, I guess, pumping gas when I guess he slipped and fell. And you can see here, his fracture is a little bit more nuanced, or a little bit more complicated. He has a fracture line that goes all the way through the vertebral body there. And also that front part of the anterior inferior portion of the vertebral body seems to almost have broken off. And on the MRI stir sequence, you can see there's hyperintensity in the back, so suggesting that there's likely ligamentous injury in the posterior ligamentous complex. So He came in luckily with just severe back pain, but also an intact neuroexam, so no weakness, no numbness. So from the Denise spinal column, paradigm, you can see that, there's anterior column, there's middle column, and because of the ligamentous injury, there's posterior column. So this is a 3-column injury. From a TLIC standpoint, I would call this probably a burst fracture, because basically the burst fracture means basically a fracture that goes from the anterior cortex to the posterior cortex, and then there's some concern for maybe a little bit of retropulsion or the bony fragments, pushing back that you can see there. The posterior ligamentous complex is almost definitely injured, given the amount of stir signal intensity, and luckily he again is neurologically intact. So it's a 2 and a 3, which make it a 5. And then in terms of AO classification, you can see that this most closely resembles a B2. So basically there's a fracture through the body, and then there's a tear through the posterior tension band. So it's a B2. So this is unstable and this is operative. So we actually did take this patient back for surgery and stabilized him with rods and screws. So, switching gears real quick, now that we talked about stability, let's talk about sort of alignment and sort of sagittal balance, or no, sorry, spinal balance overall. So, the spine, if you think about it, your posture is ultimately composed of or determined by 2 things. One is the actual positioning of the bones in your spine, so the actual spinal alignment. And the other thing is sort of your paired muscle structure. So you imagine sort of very simply, if you look at someone standing up, they're using neck extensors, neck flexors, spine extensors, spine flexors, hamstrings, quadriceps. So all these muscles are sort of paired. And, you can imagine that basically the most harmonious or the least energy taxing position is if everything is in line. So the head is over the torso, which is over the pelvis, over the legs. And then you use the least number of muscles to keep yourself up in that position. So again, the idea that's dictated by spinal alignment and paired muscle groups. And again, this is the idea you want everything to be over your femoral heads. And the other thing to think about is, our spines are not, made to be straight. So, it's not like we're building a tower, but rather it has, known curves. So for example, the cervical spine and the lumbar spine both have lordosis, and the thoracic spine is classically kyphotic. And there's different sort of thoughts as to why this happens. A lot has to do with shock absorption, and the idea that if you had just if we were built like towers, then you have a lot of forces on the bones themselves and wouldn't give us nearly as much flexibility. Another thing we'll talk about is pelvic incidence, which I'll talk a little bit more about, but that's also about how your pelvis is shaped, whether it's going to be flat or steep compared to your femoral heads. So, what are the reasons that you have spinal imbalance, right? So, you can have congenital or idiopathic. So these are people who are born with, spines that are imbalanced or out of alignment. So this is your sort of childhood or infantile scoliosis or your adolescent idiopathic scoliosis. Aging and degeneration, and we'll talk more about this as well. But as you age, the wear and tear and the arthritis and the aging process in itself can cause your spine to be out of balance and out of alignment. Oncology, so basically oncologic issues. So in this case, you can see there is a metastatic lesion that's sort of taken over that vertebral body, and it's starting to kyphose. And so that's also a possibility that you sometimes see. Trauma, of course, we've talked about, infection. Neuromuscular diseases can also affect it. And iatrogenic, which basically is a fancy way of saying that we did it. So surgery can cause spinal deformity and spinal imbalance. And this has to do with the fact that, you sometimes will see patients who have been fused in a position that's not natural, or is too flat, or doesn't sort of take into account the balance and alignment of the whole spine. So this, sometimes we call this flat back surgery, and we'll talk a little bit more about that. So talking first, we talk about balance. We can think about it in 2 different planes. There's a sagittal balance, and then there's a coronal balance. So sagittal balance is basically your side view. So you look at someone on the side, your side profile. So a couple of things that we can start looking at and measuring to sort of talk about, sagittal balance in a unified way is the C7 plumb line. So you draw a line from the middle of C7, and you drop it straight to the ground. And then basically what you want to do is what that shows you is, especially in an upright standing film, because these measurements are all done in upright X-ray standing films, because you want to see what the natural or what the native alignment is, and that's probably best seen when you're standing. It basically shows you how much of the weight of everything is pitched forward or backwards as in relation to the actual pelvis. So there's a sagittal vertical axis, or SVA. Basically, that's the measurement between where this line falls and the posterior superior aspect of S1, so the top of the endpoint of S1. And so that measurement is drawn, and that's known to be your SVA, and it should be less than 5 centimeters. And I put a little asterisk there because we'll talk a little more about this later. But having to do with age and aging and things like that, that's not a hard and fast rule. But the idea is basically that your weight should for the most part be within 5 centimeters of the sacrum there. So, if we talk about the sacrum again, and like I said, it's not built like a tower, but we think about building it like a building. You want to start looking at the base. So, looking at the base of the building, if you will, we start looking at spinal pelvic parameters. And, we talk about a couple different angles and measurements here when we're talking about this. So pelvic incidence. So this is, in layman's terms, sort of how your pelvis is angulated with respect to your femoral heads. And this is something that people are born with, and you can't change it. There's no positioning that you can do to change it, but this is just how steep your pelvis is. And it's sort of, you measure it by taking the sacral end plate, and then you draw a line 90 degrees perpendicular to it. And then you go from the middle of the sacral end plate and you go to the femoral head. And this angle here, that's your pelvic incidence. Again, not modifiable by positioning. This is something that you're born with. And quote unquote normal is between 40 and 65 degrees. The next angle we'll talk about is pelvic tilt. So pelvic tilt is modifiable. So pelvic tilt, I like to think about as this is the degree of compensation that people have, that people do use to compensate for any spinal imbalance. And so it's measured by forming a vertical line drawn straight to the mid femur. So just drop a straight line down to the femur, and then you draw that line to the mid sacrum. And that's your pelvic tilt angle. And so again, modifiable with positioning. So if you imagine, and I'll show you that picture in the next slide, as you lean forward, your pelvic tilt decreases. As you lean back, you can imagine your pelvic tilt increases. And so, it's a measurement of compensation. So especially if a patient's overall spinal alignment is that they're pushing them forward, sometimes people will deliberately tilt their pelvis back in order to compensate and make sure to make that spine, functionally more in line. And normal is around 10 to 25. And again, people who are compensating tend to have a pelvic tilt much higher than 25. And then sacral slope is just, I think of it as a calculated measurement. Basically, it's the angle of the S1 end plate that it makes with a horizontal line. And the relationship between pelvic tilt and pelvic incidence is pelvic tilt plus sacral slope is pelvic incidence. So, it's one of those things where if you know two of them, you can calculate the third. So this is what I meant by pelvic tilt compensation. So you can see here on the left side, the patient's spine is very flat, and you can see the C7 plumb line is drawn, right in front. It's way in the front of S1, and this is their native pelvic tilt. But as they try to compensate by being able to look up, they'll tilt their pelvis back. And now, if you see here at this angle, they've tilted their pelvis back enough that they're, basically functionally straight now. But because of the reason that because of the tilting that needs to occur, they actually need to bend their knee in order to make sure that their weight is balanced. So again, this is one of those things where you can hide. If you look at a patient like on the right, you can say, oh, well, they look pretty balanced, but they're hiding it using their pelvic tilt. Lumbar lordosis, so sort of moving on up, it is basically the angle, the curvature that you get from the lumbar spine. And so it's measured by something called a Cobb angle. And basically what you do is you take a line that traces the top of the end plate of S1, a line that traces the top of the end plate of L1. You draw perpendicular lines, and this intersecting angle, this B here, is the lumbar lordosis Cobb angle. And so the idea is that the lumbar lordosis in many ways is supposed to match your pelvic incidence. So your pelvic incidence is how you've tilted your pelvis forward. The lumbar lordosis should, in a sense, be able to compensate and bring you back to close within 9 degrees. So, basically PI, and we talk about the PI-LL mismatch. That's the idea of, if you take your pelvic incidence and you subtract your lumbar lordosis, how close are you? And so normal PI-LL mismatch is about plus or minus 9 degrees. But again, this is something that we'll consider, can change with age. And ultimately, the question is, what is the SVA in relation to this? So, for example, but doing just the PIL mismatch, you're just looking at the relationship between the lumbar spine and the pelvis, but there's a lot of other spine above. And so the question is, where does that C7 plumb line bring you? So, one of the sort of guiding principles of this, of spine surgery, at least in terms of deformity, is life and sometimes spine surgery, as I mentioned, is progressively kyphotic process. And so, a study by Asai in 2017 actually kind of looked at this. So they took 1,461 patients who had no issues with spine disease or surgery. And basically they measured their SVA, lumbar lordosis, thoracic kyphosis, and pelvic incidence. And so you can see here, this is kind of a busy slide because there's a lot of numbers here, but a couple takeaway points. If you look at both men and women, looking at their sagittal vertical axis, again, this is sort of how far that C7 plumb line is in front of or behind the S1 posterior superior end plate. You can see that, when you're younger, you actually tend to have a negative vertical axis, sagittal vertical axis, but as you get older, you normally, if you will, as part of aging, causes you to have more of a frontal SVA where you're tilted forward. And you can actually see here, basically you can look at the mean lumbar lordosis. You can see with age, what happens is those joints become more degenerated. So you don't get as much of a bend in the lumbar. So as you get older, your lordosis actually decreases. Okay, and so Lorraine here said, very insightful. What instruments are used to measure these parameters? So really, these parameters are radiographic parameters. So what it is you basically go in. I can actually show you. Actually, in the next couple of slides, you measure them on a standing X-ray. So you usually there's the imaging program that you're using usually has these measurements that you can then measure with the program on standing X-rays, and that's really how you measure it. It's really no good way to measure this in clinic or when seeing the patient. It's a radiographic measurement. So this, this adds to the thing that I think we all know sort of intuitively, is that as you get older, you tend to be more hunched forward. And so, people will talk about, the dowager hump or whatnot, but, these numbers truly do show that, this is in a sense a normal aging process. As you get older, you tend to kyphose over more and more. And another thing you can see here is that, as you get older, to compensate, you can see patients will oftentimes, extend their head, or extend their neck and head in order to look forward. And then that's a very important thing to think about. So ultimately, that's probably okay. I mean, the idea is that, maybe this is probably something that's, in a sense, normal, if you will. And you can see here, when they looked at pelvic tilt, again, this is the compensation that someone does, by tilting their whole pelvis back in order to, bring their body back. You can see that, again, with age, you have more pelvic tilt, which makes sense. So, as people get older, they're kyphosing forward, but they're compensating with their pelvic tilt. Lefage in 2016 also looked at sort of disability. So the idea is that, how much of this is actually leading to people being disabled and not being able to do certain things. And so they looked at sort of equal amounts of measured disability. So so say, among all people who are mildly disabled, they looked at the older patients and they looked at the younger patients, and they looked at the PILL, SVA, and pelvic tilt. And you can see here, under all patients with moderate disability, the same amount of disability, older people tend to have, more pelvic tilt, had more of a PILL mismatch, and had a more forward, more anterior sort of leaning SVA. And so this goes to the idea that, again, this may be something that's just part of the natural aging process. So, older patients, don't want to live in a perfectly balanced SVA or perfectly balanced PILL, but rather this is sort of part of what they normally want to see is the idea. So, so when considering older patients, you don't necessarily want to correct them to 0. So you don't want your SVA to be exactly 0. You don't want your PILL mismatch to be exact, but rather it seems like these patients like to be a little bit forward, and that's where they naturally live. So takeaway point here, numbers are only part of it, right? So, ultimately I'll be talking about a lot of numbers, a lot of different measurements here, but, treat the patient and the symptoms. So, if the patients, got the numbers are all, out of what's considered normal, but they're doing fine, they're functionally independent, and they're doing okay, no reason to do surgery. So a couple examples here, so This is patient PR. He was a 69-year-old gentleman, low back pain, basically with walking and standing. And you can see here, just looking, even without doing any measurements yet, you can see this is a standing x-ray. Couple of things to note: the lumbar spine is actually curved the wrong way, if you will. So it's kyphosed instead of lordosed. And you can kind of get an idea that, it seems like he's tilted forward a little bit, okay? And once you actually do the measurements, you see that it's actually very true. So first of all, SVA, taking the C7 plumb line down, is about 9 centimeters, which again, normal is around less than 5. Pelvic tilt is 30 degrees, so that's a little higher than normal. So there's some sort of some compensation that's occurring. He's tilting his pelvis back to bring his spine back into alignment. And the pelvic incidence is 45, and that's again the slope of the pelvis itself. And lumbar lordosis is only 7.8. So a PILL mismatch of 37. So basically, if you consider normal to be less than 9, 37 is very forward. There's a lot of mismatch there. And you can see just, looking visually here on the CT, you can tell that the lumbar spine, if anything, is just very, very flat. There's a lot of flatness here. And so that could be contributing a lot to his disability. This is JPY. So this is a patient who actually had previous surgery at another hospital. 72-year-old actually had a previous L2 to S1 fusion, now with worsening low back pain and inability to stand, actually couldn't stand up. And a couple things to note even before you do the measurements here. So previous hardware here, you can see that, despite the hardware, it's still very flat in the lumbar spine. And it looks like there's actually a little kyphosis at the top. And, this is something that we call, proximal junctional kyphosis or adjacent segment disease. But you can see here also that an interesting thing is the screws have kind of pulled out a little bit. You can see at the top screws, they're further back than the bottom screws here. And that has a lot to do with sort of the way that the rod is shaped. And we'll talk a little bit more about that later. But if you do the measurements here, you got your SVA of 10.3, again, normal, so less than 5. Pelvic tilt to 17. So actually in this image, he's actually not compensating very much. So, it's, this is a true image. So what you're seeing here, the SVA is not being sort of artificially decreased. Pelvic incidence is 54. Lumbar lordosis is 15. PIL mismatch of 39. So again, a good amount of significant mismatch there. So let's talk briefly about the coronal balance. So we talked about sagittal, and so that again is the balance you see on side profile. But what about looking straight at someone? That's the coronal balance. So biomechanically, very much like sagittal balance, it makes sense to have your head and your torso, the center of weight, to be centered above the mid-sacrum, so the middle of the sacrum there, like that, and to be between both femoral heads, right? So that way you're not putting more weight on one leg, and you're not trying to compensate by using different muscle groups. So overall coronal balance assessment, you can use something called a coronal C7 plumb line. That's similar to a sagittal C7 plumb line, and a line called the coronal sacral vertical line. And I'll show that in the next slide here. But you hear the term scoliosis thrown around a lot, and scoliosis basically is when there is a coronal curve that's greater than 10 degrees. And whenever there's, and oftentimes, with scoliosis, there's a rotatory component. So it's not just that, there's a bend, but rather the vertebral bodies are actually rotated. So it's not just a lateral bend, but also a bend in a rotation. So looking here, the coronal sacral vertical line, basically, again, on upright x-rays. So all these measurements are done on upright x-rays to see what their sort of natural alignment when standing up is. So you draw a horizontal line connecting the iliac crests, so like that, right? And basically, you then draw a line perpendicular to that line that also bisects the sacrum. Okay, so that's your CSVL. And the reason you do the iliac crest is because you want to differentiate between an imbalance that's due to the spine and an imbalance due to a leg length discrepancy. So some people have actually leg length discrepancies where one leg is longer than the other, and you'll see in those patients one crest will be higher than the other. And so if you draw a line across the crest and you do the perpendicular line, that gives you sort of a way to calculate out that leg length discrepancy. Again, you can draw a C7 plumb line, so middle of C7, you drop it down to the floor, and then basically the coronal balance is defined as the distance between the CSVL and the C7 plumb line. And so just at a convention, if the patient's to the left, then value is negative, and the patient's to the right, the value is positive. So this, gets into the Lanky classification, and this is sort of out of the scope of this talk, because again, this is one of those situations where we probably have a whole talk on the Lanky classification. But Lanky basically proposed a classification for adolescent idiopathic scoliosis, and you can see it's actually quite nuanced. A couple of things I wanted to point out here is that there's different curve types, and he made a distinction between structural versus non-structural curves. So it's important to think about structural curves are curves that can't be reduced, can't be changed with positioning. So you'll oftentimes get a patient with a coronal curve. You'll have them do a lateral bending film, bend to the left, bend to the right, and to see if that curve reduces back down to straight. If it doesn't, it's a structural curve or a rigid curve. And if it does, or if it is correctable with position, it's called a non-structural curve. So between sagittal and coronal balance, the question comes down to, well, what's more important? If you can only fix one, what's the more important to how well people live and what their quality of life? So this paper by Dobbs back in 2013 looked at that. They took 85 patients with sagittal and coronal imbalance, and they used what's called an ODI, or the Oswestry Disability Index. This is just one of the many different surveys and categorizations that you can look at to see how disabled someone is. And they looked at it before and after surgery. And their conclusion was basically that sagittal balance improvement is the strongest predictor of improved outcomes in patients. So sagittal balance matters the most, especially in patients with both sagittal and coronal imbalance. And actually, they said in coronal imbalance alone, improving the coronal imbalance was not a factor for predicting improved functional outcomes. So while this goes back to the whole idea that you treat the patient. So if the patient has coronal imbalance, fixing that alone won't necessarily give them better quality of life, unless you can pinpoint a specific symptom that is due to that coronal imbalance. So just as an illustration of looking at how we sort of measure these things, this is MH. She was a 28-year-old woman with history of adolescent idiopathic scoliosis. She knew about it, but sort of lived with it, but then came in because she's had worsening mid-thoracic pain. You can see here she has a scoliotic coronal curve there. And so the way we measured is, again, through Cobb angles. And you can see here, we break up the curve. And so, we first of all looking at the CSVL, you can see that the distance between the CSVL and the C7 plumb line is only about 1 centimeter to the left. So that's not terrible. The major curve is the curve with the biggest number, the largest degrees of bend. So that's in here, the right-sided thoracic major curve. We measured it at 45 degrees. And then there's two lesser curves, minor curves, a 33 degree curve in the upper thoracic and a 22 degree curve in the lumbar. So, how do we correct? So I talked to you, just showed you a bunch of different deformities, and say we're going to surgery, how do we correct these deformities? And so that comes down to the idea that these deformities again are rigid, if you will. They're not, for example, if I was to take pictures of my spine while I'm doing certain positions, bends and whatnot, I could create an artificially looking scoliotic curve. But true scoliosis and true deformity is one that it can't be modified, can't be changed with positioning. So the spine is rigidly imbalanced, and so correction really relies on you doing certain releases, as we say, and to basically destabilize or loosen the spine in that location, and then realign the spine, and then stabilize it in a more balanced configuration. So, talking about releases, we can think about the different approaches to go in and release the things that make a spine rigid. And so you can think about an anterior approach. So, coming from the front, going through the ALL, taking some of the disc, and maybe even taking some of the PLL to release the spine anteriorly. Posteriorly, you can come back, and from the back, take the interspinous ligaments, take the ligamentum flavum, take the joints, and that will allow posterior release. And then lateral, we'll talk a little bit about. It's more of a newer way of release that has been done with MIS, and that's sort of emerged in the last couple of years. So talking first about posterior release and correction. Posterior release really is sort of the workhorse of deformity correction. It's probably been around the longest. And the idea is to release the posterior ligament. So you basically cut the interspinous ligaments, the supraspinous ligament, you take out the ligamentum flavum, and also you make osteotomy cuts or bony cuts into the joint to disarticulate the facet joints, and that basically loosens up the spine for you. And of course, you can also do some bony element reduction. So basically, you go in and you take out certain pieces of the bone in the back to allow you to have more correction. And we'll talk about that here. And this brings up, the Schwab classification for osteotomies. So Schwab in 2014 basically classified the different bony osteotomies or the bony cuts you can do to A, loosen the spine, and B, also get sagittal correction. So, type 1 is just, you basically go in, you cut out the inferior articulating process, and that gets you about 5 degrees of sagittal correction. Ponte, or sometimes it's referred to as a Smith-Peterson osteotomy, is where you take the inferior articulating process and the superior articulating process below, and that'll give you 5 to 10 degrees. A pedicle subtraction osteotomy is basically when you go in, you take out almost all the posterior elements at that level, so spinous process, lamina, and then the facets, and also you take a wedge out and you take the pedicle out entirely. And that can give you up to 35 degrees of correction sagittally. And then, 4 is really just a very aggressive pedicle subtraction. And then 5 is what we call either a vertebrectomy or a spondylectomy, where you just take out the entire vertebra along with the vertebral body. And that can get you up to 45 degrees per level. So how these get you to those degrees of correction is really you go in, you take out that piece of bone, and then basically using a combination of rods and screws, you can compress in the back, and you can see that gives you more, you close down that bony opening you created, and it gives you more lordosis, to correct sagittal imbalance. Now, the question is, how do you how do you correct coronal imbalances in this situation, because we're talking about sagittal balance correction. So the osteotomies themselves, are actually releases in this case that allow for mobility to correct curves that cause spinal imbalance, so even coronal curves. And so this is a video here where, if you imagine after you've done those osteotomies to open up those joints and give mobility to the spine, you can then go in with rotational devices or even just rods, and you can rotate the spine back into an alignment that's better. Excuse me. All right. So anterior release strategies. These also happen a lot, and basically, this is basically going into the front again, taking the anterior longitudinal ligament, taking out the disc, and basically inserting an inner body to change the overall alignment. You can see here, this is more lordotic because of that oversized implant that they put in. Again, it's done through the retroperitoneal space. And again, involves releasing the ALL, discectomy, and inner body. And sometimes people will do osteotomies from the front as well. And so you'll hear about these cases, people talk about them as A-lifts or O-lifts or ATPs. So A-lift is anterior lumbar interbody fusion. O-lift is oblique lumbar interbody fusion. ATP is anterior to psoas, and basically just talks about the different angles you can approach the spine from the front. So lateral releases are relatively new, though frankly at this point they've been around for a couple of years. And the idea is that you can then come in from a minimally invasive approach, and you can actually go through the psoas muscle to come at it straight lateral. So you take a patient on their side, and you can dock a retractor down and get you right at that disc space. And so again, relatively new through the psoas. And the benefit of this is you can actually put a very large inner body in. So you can see here, this is a paper from Paul McAfee, and you can come in from the side. And in this patient with a coronal curve, he was able to get in a very large inner body that sort of spans the whole medial lateral aspect of the disc. With a combination of screws and rods, he was able to make that coronal curve back into a straight spine there. The downside of this is, by itself, there's not very much correction that you can do through this minimally invasive approach. So usually, if there's a large curve, you have to use pedicle screws and rods to sort of augment. So looking at sort of the different patients I brought up, this was a 69-year-old with back pain. We went ahead and did a T11 to pelvis with multiple osteotomies. So type 2, Schwab 2's osteotomies at the bottom, and then Schwab 1's at the top. You can see here, just on examination here, the lumbar lordosis went from 7 degrees to 34 degrees. So we added a good amount of lumbar lordosis. And therefore the PI-LO mismatch went from I think it was 39 or something of that nature, to 11, which is much closer to normal. And the SVA I mentioned here is actually 2.17. So, that's very close to, that's very normal. And the pelvic tilt went from 30 degrees to 25 degrees. So again, because he's further back now, he doesn't have to tilt his pelvis as much to allow for better alignment. So, and of course, the most important part, functional improvement, much improved in back pain, and he's actually back golfing now. So JPY, again, this is a patient who had prior surgery, worsening back pain, unable to walk. We did an extension of fusion T11 to pelvis. You can see here, we actually, for the SVA, we were able to bring him back. SVA is now only 3.86. Lumbar lordosis went from 15 to 32. And again, for a PILO mismatch of 22 degrees. And this again goes back to the idea that, he's 72. Yes, PILO mismatch of 22 is technically not normal, but, likely, because he's getting older, he's probably going to be able to tolerate just a PILO mismatch of 22, even though it's not within 9. And, he had significant improvement in back pain after surgery. And this is sort of this is a coronal curve. Again, we did a T2 to L2, T2 to T12. Post correction after surgery had much improved mid-thoracic pain. You can see here we were able to, through a combination of releasing osteotomies, straighten that spine to look much more normal after surgery. So the last part I'll talk about is sort of spinal instrumentation. And this is sort of, an overview and sort of touching upon, a couple topics that are actually very complex that, just to get an idea and sort of touch upon these things in terms of things you're thinking about when you're putting screws in and putting hardware in. So general categories of spine instrumentation, there's screws, there's rods, there's inner bodies and cages. And then, there are things that I consider adjuncts, so hooks and connectors and wiring and whatnot. So, sort of fundamentally, you think about what is the purpose of instrumentation? Why do you put screws and rods in? And, it's because you're trying to correct an alignment, but also fixate. So, people talk about fusion surgeries. Really what we're doing, in time of surgery is not really a fusion, it's actually a fixation. And the distinction there is basically this, is that, a fixation is basically the idea that you're putting the rods and screws in, and the rods and screws are what's keeping that spine in a certain alignment. A fusion is a process that occurs once that bone starts to heal, and what happens ultimately is that with the rods and screws in, the bone, all the bones, vertebral bodies that you put inside your construct, your fixation construct, will grow together, and there's bony growth across the joints, across the different levels, so that they grow into a single level. It acts like a single bone. So really, the point of these rods and screws is to really just give structural support until the bony fusion can occur. So really the bony fusion, the body healing over with its own bone is the ultimate goal. And the rods and screws aren't really meant to last forever. So we talk about the idea of spinal instrumentation harmony. And, I think harmony is one of those things that gets thrown around a lot. And, I'm sure this is a definition that is different from someone else that may refer to spinal harmony. But it's the idea that, basically, because of all the powerful tools we have to loosen the spine, we can really put the spine into any sort of alignment that we want within reason. But the idea is that you don't want to try to add curves where there aren't curves. You don't want to put straight segments where there should be curves. So again, the idea is to contour the rods, when you put the rods in, to contour them to approximate a natural alignment. Again, that's lumbar lordosis. At the upper lumbar and thoracolumbar junction, more of a straight, and then thoracic, again, is kyphotic, right? So, you want to maintain most of the lordosis in the lower lumbar spine. So you can see here, based on, this diagram, most of the lordosis happens here. And so that's one of the issues with this construct here, the way that this rod was bent. You can see there's a good amount of bend at the very top of the construct near L2. And so basically what this construct is trying to do is trying to get a lot of that lordosis at the top instead of where it naturally belongs, which is at the bottom. And that can lead to screw failure, screw pullout, and a need for revision surgery. So again, the thoracolumbar junction where they put that bend should be straight to mildly kyphotic. And Lefage in 2018 also showed this and basically said that, to prevent instrumentation failure, lower lumbar should actually take up about 60% of your lordosis. So 60% of your lordosis should happen at the bottom of the construct. And, roughly L4 to S1 down here should be about 50% of your total lordosis in your lumbar spine. So, trying to put lordosis at the top tends to lead to increased failure. So other things to think about, not only just where you put the instruments, but also what instrumentation to put in, what screws and what rods to put in. And this gets very sort of material science, physics very quickly. But you have to think about sort of the ideal material that we put rods and that we use for rods and screws. So rods, we want them to be stiff enough to hold a specific shape. But if you can imagine, once you put a rod in someone's back, there's going to be sort of micro motion and motion in everyday activities, right? So your spine's not meant to be perfectly, stationary. So you also want the rods to be flexible and not brittle, so that during that sort of everyday wear and tear, it doesn't just, snap and fracture. Screws and interbodies, you want them to be strong enough to not fracture and not break, but also not too stiff to cause subsidence. And I'll talk about that in the next slides here, this term subsidence. So, this again gets very sort of physics heavy, but, there's this concept of what's called a Young's modulus. A Young's modulus is a property of a substance that basically determines its stiffness, the stiffness of a solid material. And so, it's the relationship between stress and strain under a uniaxial force. Now, again, there's mathematics to this, but what does this really mean? So this means that basically, for a standard, a substance, solid substance, is what's called the elastic region, which means if you imagine taking a rod and you try to bend it a little bit, and then you let go, it springs back to its normal position. There's that elastic region. At some point, if you're very, very strong, you'll get to the limit of the elasticity, and after that, you truly bend it. So, if you're very strong with a rod, you really, really try to bend it, at some point, it'll hold its newly bent shape. And so, the Young's modulus really talks about what the slope of this is, how much force, how much strain is needed in order to cause a certain amount of stress. So, the larger the Young's modulus, the stiffer something is, if you will, and the smaller, the less stiff it is. So if you look at sort of cortical bones, so, the bones that we're putting, screws and rods in, their Young's modulus is only 14 gigapascals. Where if you get into looking into the things that we put in, titanium alloys get up to 105, 120. Steel, which stainless steel used to be a large part of the implants that we put in, 200, and things like cobalt chrome up to 200, 250. So what does this really mean? So like subsidence is the idea that when you take something that's very stiff, this box with a large E, and you push it up and force it down onto something that's less stiff, it'll sink in or subside. And this is not good for spinal instrumentation, because you want the instrumentation to support the spine and not destroy the spine by going through it. So the way I think about it is, if you have a large styrofoam block, right? And so you take a large styrofoam block and you take something like a brick, and you put it on top of the styrofoam block, and then you put another styrofoam block on top, and then you say you apply force down. You can imagine that brick is just going to go right through that styrofoam. It's going to sink into that styrofoam and indent it. So if you imagine, that's sort of like the bone. So in some patients who have softer bone, their bone really is like that styrofoam block, and the brick is the titanium implant you're putting in. So that's something you should think about, whenever you're putting these things in, is to, are you putting in something with such a high Young's modulus that you're increasing your chance of subsidence? This also comes into the idea of screw pullout. So I know before in that patient we talked about with an L2 to L2 to S1, there's screws pulled out. And so part of that is also this idea that, if you take a screw that's very rigid and very stiff, and you put it into bone that may be less rigid and less stiff, like this, represented by this apple, with the standard motion that happens with everyday movement, everyday tasks, you can pull the screws out because of the differences in the stiffness. You can see here. So you imagine sort of the apple, is someone trying to bend over or whatnot as part of everyday life, and then screws just pop out. So also something to think about in terms of, how Young's modulus affects that. So last thing I'll talk about is, again, very, very physics-based, but, this idea of Wolff's law. So the idea is that, bone itself, in a physiological state, it takes stress and strain to build more bone. So what that means is basically, if you say you're an athlete and you do a lot of, activities that require you to jump and land and exert a lot of force on your bones, they actually will be stimulated to lay more bone down. So if you look at athletes, they tend to have much denser bone and higher bone quality than if you're someone who's very, who's very sedentary and doesn't do a lot of activity. It's the idea that, again, modeling of the bone is secondary to mechanical transduction. So increased stress leads to increased bone density. So this gets into the idea of stress shielding. And again, this is a very complex topic, but I'm just going to touch upon it briefly here, is the idea that, normal bone sees a lot of stress, during the day and during everyday tasks, where you can constantly imagine your weight being constantly pushed down onto bone, and there's a lot of force associated with that. And so that force actually increases the likelihood that that bone is going to have more density packed into it, and the bones will get stronger. When you put things in like inner bodies, or you put things in like screws and rods, you can imagine that some of that stress is being shielded, if you will, or being compensated by the actual rod. So your bone will see actually less stress, and that can actually lead to bone loss and worsening bone quality. If you put an inner body in, you can imagine that how the forces are transmitted through that inner body change, how much force that each portion of the bone is seeing. So for example, here, these are pressure diagrams. You can see red is higher pressure, and then blue is lower pressure. You can see based on just the different just the different materials that you use for inner bodies. Titanium, for example, has a lot more stress on the surrounding bone, and PEEK actually stress shields the bone pretty significantly. So ultimately, this just means, you want to optimize your instrumentation. You also want to optimize the bone. So the first, how do you optimize the bone? You look at patients and you check their DEXA score. So you make sure that their bone quality isn't already decreased due to, something or another, some sort of underlying osteoporosis or underlying endocrinological issue. So, sometimes if you see a patient with a low DEXA score, you may send them to endocrinology for medical management with bisphosphonates or, any of the other PTH analogs to try to get their bone better before you do maybe a larger surgery. You want to minimize the violation of normal bone. So, cortical surfaces, the idea is just to not take any bone that you don't have to, because the more of the normal bone that you take of the patient, the more you're weakening the spine. And then always choose the least stiff option that still allows for goals of surgery, meaning that, the stiffer the instrumentation, the more force you can exert on the bone in terms of correction. But ultimately speaking, you don't want it too stiff. Again, the idea is that it causes things like subsidence and screw pullout. So cobalt chromium is often used for, for deformity cases in younger patients because it's the stiffest and it allows you to have the most correction, but it's used mostly in younger patients because their bone quality tends to be really good. Titanium is kind of a good all-rounder. It's stiff, but it has a little bit of flexibility. PEEK is actually a type of polyester ester ketone. It's a polymer basically that is a lot less dense than titanium. And of course, autologous bone. So if you use cadaveric bone as your inner body, then that tends to have the most approximate the patient's bone the best. So final thoughts after talking about all this, I wanted to say, first, the key thing to remember is you always need to treat the patient. So again, I've talked a lot about the different parameters and the different things that you can look at based on, radiology and the images you have. But really the symptoms matter, right? So like, why are they here to see you? Especially neurological symptoms, so if they have weakness, if they have numbness, if they have radiculopathy, that's more important. You shouldn't treat someone based on just how their imaging looks, whether that's CT, X-ray, or anything like that. So again, do not treat the imaging, and not everyone needs surgery. So, ultimately the idea is that, sometimes non-operative management is the best option. And so again, this goes to the idea that surgery is an option of last resort. And I think that should always be the case. I mean, you're doing something that is very unnatural, if you will, that requires, a good amount of recovery and has a lot of risks. So things like physical therapy, weight loss, pain management should always be the first option. And when they come to see you, it should be because they failed all these options. And in general, don't perform a large surgery when a small surgery will do. And this comes down to the idea that, again, you try to pinpoint where the problem is coming from and just do the small surgery. There's always a chance for more surgery in the future if things happen. But you should not, start off with the idea of doing a large surgery. There are my references, and then I'll take questions. I think I have a couple in the chat here. Let me see here. So in type 3, it is a good outcome. I mean, about affects spinal cord length after this procedure and about quality of life not affected. Okay, so you're saying in type 3, I think you meant, I think you're talking about the Schwab type 3. So yeah, so does it affect the spinal cord length? So in some ways it does. So yeah, this is the Schwab 3 here. So yeah, it does cause your spinal cord to shorten, if you will, meaning that, basically where it was, if you imagine sort of a rope being pulled taut, as you close down on that osteotomy, it does become less taut and loose. So the spinal cord actually will tolerate a good amount of shortening, if you will. The only part that the spinal cord doesn't tolerate is if you were to make it more taut. So if you were to lengthen your spinal cord, or lengthen the column that your spinal cord goes through, that tends to have neurological deficits. But having a little bit of shortening actually makes the spinal cord less taut and then less under tension and under stress. Quality of life, is actually, so it depends on when you mean. What do you mean by quality of life? For the first 6 weeks or so, you're talking about, pretty significant, difficulties with pain and getting up and things like that. So yeah, certainly, during recovery, these patients will often say that they're not happy, but I think after recovery, it really does affect quality of life a lot, because you'll be surprised with how much, especially when someone has a deformity that causes them to not be able to look up straight or have to use a lot of muscles in order just to keep their head level and look up straight, how much that is taxing on the body. So people will say that they are much more comfortable, much more happy, and actually have more energy because they've spent less of their day, their muscle, just trying to keep themselves upright. Okay, so Adrian said, most of the patients are over 45 years old and a female sex. Is there a particular reason for explaining this choice? Moreover, knowing demineralization increases with age and that women are prone to osteoporosis, what percentage of the alignment correction is successful? Okay, yeah, so, over 45, yeah, that's, in general, I've shown a lot of patients who are of the degenerative etiology for spinal deformity and misalignment. So that is sort of the age group, and you'll see more, over the age of 50 and 60. But certainly that is ultimately sort of the age group that you see a lot of these deformities. In terms of female sex, I mean, I think, you see these, in both males and females. I'm not sure if, specifically there is a more increased female predominance, or rather they just happen to be the cases I showed. But yeah, female sex does bring up an interesting point though, because, as women age, they tend to have more demineralization and more issues with osteoporosis. So yeah, so the ultimately that does come into account. The idea that because they're more prone to osteoporosis, you oftentimes have to get, like I said, a DEXA or bone mineral density scan and get an idea of, how bad that osteoporosis is. And oftentimes we'll delay surgery, especially if something that's not, urgent, for them to go see their endocrinologist, take vitamin D, bisphosphonates or whatever, to try to make their bone quality better before we do surgery. And so, I would say that the percentage of, alignment correction being successful really comes down to patient selection. So that aspect really cannot be overstated, is just figuring out which patients, are good candidates for surgery and which patients need further workup. Let's see here. When are you going to fix the pelvis in addition to the spinal pelvic construct? Yeah, so you do that a lot. So, and I didn't talk about this because that's also in itself a different talk. But yeah, so the idea is that you fix the pelvis, you add the pelvis to your spinal construct. Oftentimes, if you have a large construct, so for a large construct, meaning say you're fusing multiple levels, you're creating a large lever arm, if you will. So all those levels that previously had motion no longer have motion, and they act as one large, single lever. So especially if you're, doing a large construct that stops at the lumbar region or S1, the lumbar screws and the S1 screw, especially the S1 screw, doesn't have that much strength. The thought is that, because sacrum has a lot of cancellous bone, there's not a lot of of strong bone there to hold onto a screw that's supposed to hold onto the weight of the whole construct. We'll then put in pelvic screws. So, you know, those come in usually two flavors, either a iliac screw, which is a little more traditional, or we'll do a S2AI alar iliac screw. And basically what that does is it adds that's a very strong screw. So if you imagine standard screws you put in the lumbar spine are, you know, maybe 7 millimeters in thickness and 50 millimeters in length, you know, an S2AI screw can be up to 110 millimeters in length and can be, you know, a 9 millimeter screw. So you can put in a larger screw that's a lot stronger, and you put that in if you want to anchor your construct to something more solid. When you put in lateral mass screws and cervical fracture, what type of cervical fracture does you think to add lateral mass in addition to anterior plate? Yeah, so, you know, this is because of the length of the talk, I tried not to talk too much about the cervical, but it's true. Yeah, so, you know, lateral mass screws are one option, you know, to stabilize the cervical spine. You know, and I think the choice between anterior and posterior really comes down to a couple things. You know, where exactly the fracture is, how old the patient is, what previous surgery there is. Yeah, unfortunately, that is something that I think, you know, I would want to go a little more into. But the short answer to that is sort of, you know, sometimes patients will need, especially in a severe cervical fracture, will need anterior fixation as well as posterior fixation. And then, you know, when you get to C1-2, you can talk about things like cervical pedicle screws and whatnot. But again, yeah, that would have to be a different talk. All right, I think I got everyone. Any other questions or anything? All righty. Well, thank you guys. Thank you for the invitation.
Thanks, Dr. Jen. That was an excellent presentation. I learned a lot too. That was great. I don't know if anyone else has any questions, but otherwise we can probably let you go.
Well, thanks a lot, guys. You guys have a good one.
Well, thank you so much, Dr. Jin, for this great presentation. We are really grateful, and it's been really insightful, and we've learned a lot. We're looking forward to having you again here at AFAN. We are so delighted. Thank you so much. We're so happy. Thank you, everyone, for being here who joined us today, and hoping that you're going to be with us again next week, same time. So if there's nothing else from anyone, if there's no question or anything, I guess we can call it a night. Is there anything from anyone before we close? Right. So I'm going to end the recording here.